I'm here with a quick question on electrolyte imbalances, which is an absolute favorite of INICET exams. Also, it was recently tested in UPSC CMS, which makes it an important topic here. So we have a question here that says, a 30-year-old man presents to the emergency department with complaints of muscle weakness, exhaustion, and nausea. His ECG shows prolonged PR interval, widened QRS complexes, tall peak T waves, absent P waves. So, given in the history itself, the history of muscle weakness, exhaustion, and nausea points towards an imbalance in the electrolyte potassium. Now, the ECG shows prolonged PR interval, widened QRS complexes, tall peak T waves, and absent P waves, gives the diagnosis of hyperkalemia. Okay, it is a definitive diagnosis of hyperkalemia. Then, moving to the options, we have calcium gluconate, insulin with glucose, and sodium bicarbonate, and beta blocker. So, beta blocker would be an answer here. Absolutely, beta blockers are contraindicated in hyperkalemia, because we know that in hyperkalemia we use beta 2 agonist rather, like salbutamol, which makes the potassium ion goes back into the cell. So it is used in the treatment of hyperkalemia. Beta blocker, on the other hand, would rather worsen or prevent this process of potassium going back into the cell. So here it is the answer. Now, explaining the further other options, we can see that the option A is calcium gluconate. So calcium gluconate merely stabilizes the cardiac membrane. Okay, it stabilizes the cardiac membrane, but it doesn't causes the hypokalemia or potassium going back into the cells as such. And then insulin is a definitive treatment, because it makes the potassium goes back into the cell, thus causing hypokalemia, or like creating a balance in the potassium ion. Then your sodium bicarbonate causes alkalosis, due to which the hydrogen ions in go out of the cells to like stabilize it or neutralize it, and in exchange to that the potassium ions goes back into the cell temporarily, and it buys time for the definitive management such as the insulin and salbutamol to act. Also, we can remember it as, since the sodium bicarbonate is creating an alkaline environment, we can remember it as alkalosis causes potassium loss. So for alkalosis is, we can remember it as all K loss. So alkalosis causes K loss, and that is, it can cause hypokalemia, and then thus it could act as a treatment in hyperkalemia. We can use it in hyperkalemia since it is causing all K loss. So this is this is a mnemonic to remember it here. And then I'd like to further compare both the conditions, that is the hyperkalemia and hypokalemia. So your prolonged PR interval is common to both hyper and hypokalemia, since it decreases the potassium imbalance, decreases the atrioventricular conduction. Okay, it decreases the atrioventricular conduction. So that's why the PR interval increases in both of them, hyper and hypo. Comparing both of these, prolonged PR is common to both of these. Then in hyper there is widened QRS, and in hypo it might be normal or slightly thinner. Okay, usually it is normal. Then in hyper we have tall PT, which in contrast to that in hypo it is flattened or might be inverted even. Then hypokalemia, you can remember it as hypokalemia. We can remember it as underkalemia. So for under, we have U wave. So U wave is a hallmark feature of hypokalemia. It is a hallmark of hypokalemia. So for hypokalemia, U wave is there, and P wave is tall peaked. P wave is tall and peaked in hypokalemia, in contrast to the tall and peak T waves that are seen in hyperkalemia. In hyperkalemia, P waves are absent. Absent P waves or like flattened P waves could be there. So this is the comparison between hypokalemia and hyperkalemia. And calcium gluconate is used to stabilize the cardiac membrane. Then insulin with glucose causes the potassium to shift back into the cells, thereby treating the hyperkalemia. And also glucose is used here to prevent the hypoglycemic symptoms. So it prevents the hypoglycemic symptoms. So that is why we use glucose along with insulin. And then the sodium bicarbonate creates the alkaline environment, which causes the potassium to go back into the cell in exchange of hydrogen ions, which is temporary and buys time for definitive treatment to act. So beta blocker would be the answer here. So there are 2 or 3 ways in which we can solve this question. That is by ruling out that these three are used, and by the fact that beta 2 agonists are used for hyperkalemia. So beta blockers would definitely be contraindicated in hyperkalemia. So this is how we solve this question. Thank you and have a nice day. Stay tuned and subscribe for more such sessions to be up that are coming next.